So hello, everyone, and welcome to the EFIM webinar about community acquired pneumonia. My name is Tuomas Aro. I'm a young internist, or at least relatively young internist. I already finished my residency, and now I'm again a resident in infectious diseases in Helsinki, Finland. I'm also a doctoral candidate. I do a PhD. I'm working on my PhD on antimicrobial resistance among asylum seekers and undocumented migrants and refugees. I'm really pleased about this today's topic. I will just give a brief story of a personal account on community acquired pneumonia. In the beginning of January this year, first my daughter had a ear infection, and then I had a flu, and then the fever already went away, but then I started again with the fever, and I started to get this really ugly looking stuff from coughing and a little bit of pain on the right side. And I was thinking, like, really, I'm having these symptoms with pneumonia, and I've never had a pneumonia before. So then, as a doctor, I thought, what should I do? But then I went to the GP, and it went smoothly. They took a CRP, which was 70 something, and then they sent me to an X-ray, and there was a lobar pneumonia. And they called me the same day at 4 p.m. that, okay, I will start amoxicillin 1 gram 3 times a day. And I ate it for 7 days, and I'm fine. And now I'm interested to hear if that went well, and maybe today's topic is more about also the elderly, which I think I'm not yet, even though I have already passed some milestones myself. But I will now give the floor to my co-moderator, Miguel.
Hi, everyone. Thank you, Thomas. I would also like to add that Dr. Tuomas Aro is one of the best photographers that I ever known. So you can add that to your biography. I'm Miguel Morante. I'm the last year resident of internal medicine at the University Hospital of Fundación Jiménez Díaz, Madrid. I have a master's degree in infectious diseases, and I'm part of the infective endocarditis team at my hospital. I'm very pleased to be here with all of you, and I would really like to introduce our speaker, our top speaker in this exciting webinar, Professor Serhat Unal. Professor Serhat was graduated from the Hacettepe University Faculty of Medicine in 1981. Between the years 1981 and 1985, he completed his specialist training in the Department of Internal Medicine at the same university. And after that, he started working his fellow in the sections of infectious diseases. Later, he started working as a clinic and research fellow in Harvard Faculty of Medicine at the New England Diaconess Hospital Department of Internal Diseases between the year 1990 and 1992. Then he completed his training as an infectious disease specialist. Between the years 2001 and 2013, he chaired the Department of Internal Medicine, and since then 2013, he was the head of the Department of Infectious Disease and Clinical Microbiology. Also, he has been the Dean of the Hacettepe University at the Faculty of Medicine, and has been working as the director of the University Vaccination Institute. In the last year, he has been working as a vice director of the same university. He's also a very active EFIM Society member, and he's been responsible for the EFIM Academy. So he's very interested in different scientific researches. For example, the mechanism of resistance to different antibiotic groups, especially in gram-positive bacteria, HIV infections, adult immunization and vaccinations, and COVID-19. He's member of both national and international scientific organizations as EFIM, and he has written more than 500 scientific articles and more than 80 book sections. Before starting, I would like to mention also some technical details about today's webinar. We in the Young Internists webinars, we have really designed this kind of webinars to be active with a lot of your participations, with questions and comments from the audience that we are going to collect and will be displayed at the end. So please, all the questions will be collected, and at the end of the presentation, we are going to ask Dr. Serhat. Also, all the microphones will be muted during the presentations. Try not to interfere with the speaker. Also, I would like to remember that the webinar is going to be recorded, and the video will be available online after the webinar in the EFIM Academy webpage and on the YouTube channel. So thank you very much, Professor. You can start whenever you want.
Well, thank you, Miguel. Thank you, Thomas. Well, I have learned a lot from my CV, actually. I didn't pay so much attention in the last years. Thank you very much for that summary. And good evening, dear colleagues, dear young interns. As an old intern, we are going to, I'm going to talk about the clinical practice guidelines adaptation for internists. Thomas, I'm very sorry to hear that you suffered from pneumonia, but today I'm not going to talk about the clinical things, actually. We'll just talk about the adaptation of the guidelines. But if you're interested in as young internist groups, I'll be more than happy to talk about the clinical aspects of the community acquired pneumonia in another presentation in the next coming days, perhaps. Dear colleagues, as you know, as internists, we are responsible of many different kinds of problems, hundreds of them. I mean, starting with infectious disease, community acquired pneumonia, urinary tract infection, going to hypertension, hypercholesteremia, written problems, coronary heart disease, whatever you say. And in all those subjects, there are so many knowledge are accumulating every day, and it's really hard to follow them sometimes. And when we are treating or when we are diagnosing, we need guidelines. And increasing number of clinical guidelines, clinical studies, and the better quality of evidence, the interested people are creating the clinical practice guidelines that help us a lot to treat this kind of many different kind of clinical problems. But although we have many guidelines, the number are very high, and although they all are evidence-based, at least using the evidence-based methodologies like GRADE, there are still documents which are poor quality and biased. And those complicated guidelines are generally written by the subspecialty groups, and they are going into the more detail of their own subjects, but some of them are not even addressing the internist. What I mean, I'll explain a little bit more in the next slide, but before we go on there, I would like to take your attention to Clinical Practice Guidelines Adaptation for Internists. It's a methodology that has been created by the EFIM Clinical Guidelines Appraisal Study Group. And those guidelines are a little bit complicated that has been created by the subspecialties, as I've told you, not mainly addressing the internists or the general practitioners, because they are more idealistic and generally do not address the multimorbidities, suffering from multimorbidities, most commonly elderly people. And those people, as you know from your daily practice, they are generally using lots of tablets. We call it polypharmacy, as you say. So in the real life, sometimes guidelines are not adapted to the real life. Just as an example, in most community acquired pneumonia guidelines, first-line treatment is penicillin plus macrolide. And as you say, macrolide is a very famous drug for QT prolongation. And all those elderly people are generally suffering for that problem. And beyond that, they are using drugs that prolongs the QT. And you cannot find any warning in those guidelines about that quite common problem. And still beyond that, all those guidelines that has been created by different countries are addressing to the antimicrobial resistance, of course, and the antimicrobial resistance are local. So the penicillin resistance in Germany is quite different than the penicillin resistance ratio than Turkey. So they are generally not addressing to the regional antimicrobial resistance. And beyond that, the viral infection and bacterial infections are generally side by side, and the clinical presentations can easily be misdiagnosed. So we have to be aware of the viral infection seasons, particularly flu season. Of course, I'm not talking about the COVID in this guideline, because when we were preparing this guideline, COVID was not on the earth yet. And all those problems, are we all internists aware of those problems? And are we informed by the authorities about those antimicrobial resistant or starting of the flu season? So because of that problem, and that problem is not the problem only for the pneumonia, of course. For example, pulmonary embolism, anticoagulation. And they are really complicated, and that does not address the issues that I was mentioning. So the EFIM has created a working group or appraisal of guidelines to the internal medicine. And the community acquired pneumonia was one of the first one that has to be decided to solve the problem. And for this one, we have organized a group of colleagues from different countries of Europe, task force members. You see the names over here from Germany, from Portugal, from Spain, from Turkey, from Italy. We all work together, and according to the clinical practice guidelines, adaptation for internists, as I've told you before, the EFIM methodology, we follow the rules over there and try to adapt the community acquired pneumonia guidelines to our specialty, to internal medicine. And in that guideline, it says to be able to make this adaptation, you have to choose the PICOs first. What is PICO? P is patient population or problem. I is the intervention or exposure or prognostic factors. C for comparison, and O is the outcome you would like to measure or achieve. So we have to define a clinical question in terms of a specific patient problem, aids the surgery in finding clinically relevant evidence in the literature. So you have to define the PICO first, a specific situation in a specific patient group, and then try to find the clinically relevant evidence in the literature for this particular problem. And for the community acquired pneumonia, as the group of as the working group of the subject, we have chosen 5 PICOs. Of course, we came out with 20-25 different problems, different PICOs, but the group has decided these 5 PICOs are the most common ones that must be addressed in this appraisal program. And you see them, I'll go into the details, so I'm not spending time for running over at this stage, because I'll go one by one on each of those PICOs, dear colleagues. Then, after we have chosen the clinical problems, we have to look for how the guidelines are addressing these questions. Are there enough answer? Are there enough practice in those guidelines? Of course, when you say clinical practice guidelines for community acquired pneumonia, there are hundreds of them. So we have to define the criteria to choose the guidelines. And according to those criteria, we search from PubMed, from NIST, from recent reviews over here, and non-English language were excluded. Pediatric ones were excluded, and we came out 350 records according to those research criteria, and the 353 of them have been evaluated, and the majority of them has been taken out according to the exclusion criteria. The most common one is the date of the guideline, actually. We haven't taken the very old ones. And then we have chosen the full text articles, and children guidelines, duplications, and non-English documents were also excluded. And we came out with for the analysis, 17 guidelines. And the group has studied all those guidelines one by one. And then finally, we came out with 6 clinical practical guidelines that has the capacity of addressing those questions and will be helpful for us for the reappraisal of the guideline. The first one was British Thoracic Society guideline, adult one from 2009. And the ECMED is the European Society of Clinical Microbiology and Infectious Disease, and ERC, European Respiratory Society, from 2012. And the guidelines for antibiotic use in adults with community acquired pneumonia, it was a good review published in the infectious chemotherapy. And from American side, Infectious Disease Society of America and American Thoracic Society, 2019. And another one for the Dutch Association of Chest Physicians, and the British one, the National Institute for Health and Care Excellence, NICE, pneumonia, community acquired pneumonia guidelines. And studying those 6 guidelines, we try to find the answers for our PICOs that we have chosen before. PICO 1. In adults with CAP, should a respiratory sample for influenza and other respiratory virus testing be taken at the time of initial diagnosis during respiratory virus season? What we mean here, and as Thomas just explained, he suffered from upper respiratory tract infections, a viral one, influenza, I think he said. And then following that, he got the bacterial pneumonia. So it may be together too, or a viral infection, viral pneumonia. It's hard to differentiate from the bacterial one. Do we have to differentiate? Of course, because we have to give antibiotic for the bacterial one. And if there is specific antiviral treatment, like the oseltamivir for influenza, we have to give that too. So the thinking that respiratory viral infections are very common in the season of the viral infections, viral respiratory tract infections, starting from the end of October or the middle of the November and coming down to end of March. Since the possibility is high, we have to keep in mind that we try to rule out the viral infection. And the recommendations in those guidelines is mentioning that in moderately severe pneumonia, I'll tell you what is moderate one according to CARP score, or in highly severity pneumonia, we have to make at least one polymerase chain reaction test or serological investigation during the increased respiratory risk activity when a patient is suspected to have a pneumonia by a respiratory viruses according to the clinical symptoms and radiological graphic findings. They both are strong recommendation, but unfortunately the quality of the evidence is low. But considering all those inputs, group decided that it is an important PICO and this recommendation must be applied during the respiratory tract viral infection season when you diagnose a pneumonia. And of course, I have to mention one more time that this document was started to be prepared before emerging of COVID-19, because during COVID-19 pandemic, 90% or 95% or almost 98% of the cases were COVID-19, But although that, we were diagnosing, of course, with PCR, and sometimes, quite rarely, they were together with the bacterial one, or following that, the superinfection of the bacterial pneumonia was also seen at that period. And the second PICO 2, in adults with CAP, should a clinical prediction rule for prognosis be used to determine whether the patient would be admitted to the internal medicine ward or intensive care unit? That is also an important question. When you diagnose pneumonia, as internists, we have to decide, are we going to treat that patient in outpatient care, or we will get him to the hospital? And if we take him to the hospital, are we going to treat him in the ward or intensive care unit? No predictive models allow unequally categorization of patients into different risk groups. Predictive models based on severity are best viewed as useful adjunct to clinical decision. And the clinical judgment is essential in disease severity assessments. Although we have lots of supports, technical supports, or the ideal supports from the chatbots or the electronic records, but still we are doctors and we still need our clinical judgment. And it's the same for the disease severity assessment of the community acquired pneumonia as well. And dear colleagues, dear young interns, as you all know, we mainly use two severity index. One is the pneumonia severity index, we call it PSI, and the other one is CURB 65 score. They all are validated scoring system, equally reliable in predicting 30 days mortality in patients hospitalized with CAP. And the recommendation again is strong, and the quality of the evidence is moderate. And the for referring patient to the hospital, quality of the evidence is even high, as you see over here. I'm not going into the details, but for pneumonia severity index, we look at the age, we look at all the serious underlying diseases that make that they are the predisposing factors for the pneumonia, bacterial pneumonia, and the demographic variables, physical findings, and laboratory and radiological findings. We divided into the from 1 to 5. 1 is young patients with no underlying disease, are generally treated outpatient setting, and all the others must go into the hospital. This is a little bit complicated. I'll show you here. You have to ask all those questions, and you give the points. It starts with age, nursing home residence, neoplastic disease, chronic liver disease, cerebrovascular, temperature, pulse, laboratory and radiographic, arterial pH, arterial blood pH, blood urea nitrogen, sodium, glucose, going on. And according to the classification, you see the classification here, and we decide either whether we treat the patient outpatient or we send him to the hospital. And the CURB score is a little bit less complicated, and it's actually, I said pneumonia severity index is hard one, but you can just go into the Google and punch pneumonia severity index. You will get everything is ready, and you can make the calculation over there. But CURB is more, much more practical. Confusion, uremia, respiratory rate, low blood pressure, and age over 65. And we give 1 point to each of them. And according to the scoring system, we decide either we treat him into the hospital or in the outpatient settings. So here you see the outpatient setting is suggested. In the outpatient setting, it's suggested to refer adults with CAP to the hospital if they have. Of course, we all are talking about community acquired pneumonia. Let me underline that again, because if the patient is acquired pneumonia in the hospital, that's a totally different story. If they have any symptoms or signs suggesting, more serious illness or condition, like the cardiorespiratory failure or sepsis, or have symptoms that has been used antibiotics before, but there was no improvement. If they had fever in the past 48 hours, or have more than one sign of clinical instability, as the systolic blood pressure less than 90, heart rate more than 100 per minute, respiratory rate more than 24 per minute, arterial oxygen saturation less than 90, or arterial pressure of oxygen less than 60 in room air. Or they can take oral medication, and of course they will need IV antibiotic therapy, and the elderly over 65 is an important risk factor for pneumonia, particularly the pneumococcal pneumonia, and the notably underlying diseases like diabetes, heart failure, moderate and severe chronic obstructive pulmonary disease, liver disease, renal disease, or any malignant disease, they must be referred to the hospital. And once they are in the hospital, patients curve 65 score. 1 is out, 2 to 3 in the hospital, 4 to 5 they generally need ICU, and you see this recommendation is strong and the quality is high. And for patients who fail to improve as expected, they should be carefully reviewed by an experienced clinician of the clinical history examination, prescription chart, and the results of all available diagnostic tests, and the referral for further diagnostic tests should be considered. Direct admission to intensive care unit, that's also possible. And here you see the IDSA severity criteria. If there is one of those two main criteria, need for invasive mechanical ventilation or septic shock, you must take the patient directly into the intensive care unit. Or if the patient has 3 or more of those minor criteria, again, must be accepted into the intensive care unit. So that is the major factor. The severity of the disease will define where shall we take the patient for treatment. And the PICO3 in adults with CAP and multiple comorbidities, as we see very often in our daily practice, should drug interactions be evaluated before starting antimicrobial treatment? That is really very rarely addressed in the guidelines that has been chosen for appraisal. And the only, I said very rare, but there was only 2019 NICE guideline was addressing checking drug-drug interaction. It's the only one. And we recommended over here in adults with CAP and multiple comorbidities, conditions or advanced age, because comorbidity conditions or advanced age means they are using more drugs. It's recommended to check for possible drug interaction with the individual patient's concurrent treatment before starting antimicrobial therapy. And there are, online databases that can be used for these purposes. And the recommendation is strong and the quality is high. There are many guidelines, but the most common one we use, as you see over here, www.medicine.org UK, NICE guidelines, summarizing here as you see over here. And in the majority of the guidelines, the interaction is classified as contraindicated, you never use it, major, better not use it, moderate, be careful, and minor or no interaction, you can use it. And here you see more examples of the websites that are talking about drug interactions. I'm sure you all are using that quite often. And the drug interactions may be because of many different problems. The most common one is the aging. As you know, with the aging, the pharmacodynamics and the pharmacokinetics of the drugs are changing, and it may affect each other. And beyond that, some drugs may facilitate the breakdown of a certain drug, or some drugs may stop the breaking down of certain drugs. So those any kind of interaction must be carefully addressed. This is not a very good slide, I know, but I wanted to show you that, and I'll send you the slides to the Academy, if you're interested in, you can get that. The common antibiotics that we use over here, as you see, aminoglycosides, carbapenems, cephalosporins, cephalosporins, they are not very commonly used for the pneumonia, perhaps, especially the outpatient setting, but we use clarithromycin, other macrolides, fluoroquinolones, and beta-lactams, penicillins. You see, there are quite famous drugs that they interact with each other. We have to keep in mind at least many famous of them, or better, we check before we start the antibiotic for the treatment. And PICO4, in adults with CAP, the factors, age, severity of pneumonia, risk factors for antimicrobial resistance, comorbidities, does it have to be considered by us while starting antimicrobial treatment? Why we are addressing that? Because, dear colleagues, as you all know, resistance to antibiotics is the major problem in the world. Before the COVID period, antimicrobial resistance was the only medical condition that has been considered as an important factor by the G20 countries meetings. I mean, we suffered from those HIV problems, tuberculosis, malaria, but only the antimicrobial resistance. And antimicrobial resistance is going to be a much worse problem in the next coming years. In 2050, it's expected that antimicrobial resistance will be the most common cause of the death in the world, will be more than even cancer and the cardiovascular factors, and it will cause more than $50 billion. So we have to pay attention to that. I mean, in general, we have to use antibiotics carefully and according to the rules, but in this particular situation, those factors, age, severity of pneumonia, and the comorbidities are the risk factors for the more resistant bacterial infection. So just as an example over here, if you are treating patient in outpatient setting, it may be viral infections, atypicals, or even pneumococci, and the pneumococci is generally more susceptible. But if the patient is hospitalized, you have to think about the gram-negatives, and they're more resistant, of course. If the patient is in the intensive care unit, so the severity defines the name of the bacteria that cause the pneumonia, even if the community acquired one, and they get more and more complicated and more resistant. And the people who are suffering from underlying diseases may suffer from the multi-drug resistant bacterial infection. And according to those factors, of course, we are deciding what kind of antibiotics we are going to use. We are going to use empirically. We are not talking about the diagnosis today, and the diagnosis, obtaining the microorganism itself and do the antimicrobial test, it's quite complicated, and it's not easy to do it. In the best conditions, you can only define only the 50% of the cases, the name of the bacteria. So we generally go into the empirical one. So according to the main factor over here is where to treat the patient. If it's outpatient, we generally, and with no comorbidities, we generally go with amoxicillin or macrolides, as Thomas has done. And he mentioned about amoxicillin, didn't mention about the macrolides. So possibly his doctor has defined the pneumococcal one, because as you know, if it's the atypicals, like the chlamydia, like the Legionella, then the penicillin is not going to work. We have to add a macrolide, or we go into the respiratory tract quinolones. So I'm not going into the detail, but the message, the PICO over here, before you start the antimicrobial treatment, and you have to define the severity of the disease and define the underlying comorbidities, and according to those conditions, you have to decide which antibiotic are you going to use that may be very different than each other for example, for the patient in outpatient setting, or for the patient in the ward, or for the patient in the intensive care unit. For example, in the intensive care unit, once it's not a problem in Turkey, but maybe a problem in Europe and United States, you have to check for the existence of methicillin-resistant Staphylococcus aureus. And Pseudomonas aeruginosa is much more common comparing to the other situations. You have to take care of them. And you have to think about that. I mean, not only amoxicillin, macrolide, or doxycycline, or respiratory tract quinolones, but you have to go into the anti-pseudomonal and the anti-MRSA bacterial antimicrobial treatment. And again, here we have to, as I told you, you have to pay attention for all those predisposing factors to be able to decide which antibiotic are you going to use. Of course, all those things must be supported by the laboratory tests, like the you can do urine Legionella test, or you can do PCR test for pneumonia, for Legionella, for the chlamydia. You have to do your best to be able to decide the which antibiotic are you going to use for those patients. And my dear colleagues, the final PICO is the PICO 5. And that is addressed quite often, but not very detailed in the other guidelines, and we brought it out. In adults with CAP, should internists use biomarkers of infection to manage antibiotic treatment? As you know, biomarkers to assess the presence of bacterial pathogens are not recommended in primary care. We mainly mentioned that the procalcitonin. CRP is quite common one. Some countries are recommending use CRP in the primary care as well, as we have seen in the Thomas example. And the C-reactive protein actually is a practical one and can estimate whether this pneumonia is bacterial or viral. A CRP level less than 20 milligram per liter at presentation with symptoms for 24 hours makes the presence of pneumonia highly unlikely, because there's no enough inflammation over there. And the level of more than 100 makes pneumonia more likely. As you see, the quality of the evidence is quite high. In primary care setting, for people presenting with findings of lower respiratory tract infections, a point of care CRP level measurement can be considered if after clinical assessment a diagnosis of pneumonia has not been made and it's not clear whether antibiotics should be prescribed. This can help to identify patients with lower respiratory tract infections who will or he will not benefit from antibiotics. And the points that we have to be underlined over here: do not routinely offer antibiotic therapy if the CRP concentration is less than 20. Consider a delayed antibiotic prescription, a prescription for use later if the symptoms worsens, if it's between 20 and 100. And if it's over than 100, you can choose to offer the antibiotics. And this is for the beginning of the antibiotic. And to be able to compare the progress of the disease, CRP should be measured on days 1, and then 3 and 4, especially in those with unfavorable clinical parameters. Failure of the CRP to drop by 50% by day 4 was associated with a 5-fold increase in mortality, ventilation, and complications. So the CRP levels may be repeatedly measured to assess the risk of treatment failure and complications in patients who do not clinically show clear symptoms improvement. And as you know, we generally do not get the second chest X-ray if everything is going okay. But if it's getting worse, then we have to check a chest X-ray, and is there any progress of the infiltration? We have to evaluate that one too. It's recommended that the duration of antibiotic therapy should be guided by a validated measure of clinical stability. So the fever will go away, white blood cells will go down, and the patient will be better. The patient will be able to start eating. So this is called the clinical stability. And then you can support that with the CRP level as well. My dear colleagues, the other biomarker that has been abused a lot in my country, and I'm sure it's the same situation in the different part of the world as well, the procalcitonin levels. It's recommended that empirical antibiotic therapy should be initiated in adults with clinically suspected and radiologically confirmed clinical community acquired pneumonia, regardless of initial serum PCT levels. I would like to underline this. I mean, CRP is a good marker and a very cheap marker to start the treatment, and procalcitonin can be used to stop antibiotics earlier than expected. So it's quite successful over there. And the repeating of the procalcitonin is also not recommended at all. Dear colleagues, those are the studies that we have done all together as a group, as the members of the EFIM Appraisal group, subgroup of community acquired pneumonia. And we were lucky enough to publish that in our journal, in European Journal of Internal Medicine, Community Aquired Pneumonia and EFIM Guideline, Critically Appraised Adaptation for Internists. And as you know, the other clinical situations are also being prepared, like the pulmonary embolia, and the anticoagulation is on the way. So I recommend you to read that patient. Everything that I've summarized is given there in details. And this was my last slide. And I would like to thank you for your attention. And if you have any questions, I'll be more than to answer for you this evening.
Thank you, Serhat, for your excellent presentation. Please use the Q&A button that you can see in Zoom to ask questions. I would like to ask about the use of fluoroquinolones. What is it's a difficult topic, but I'm even in my time as a resident and now as an internist, there has been quite a shift in how we see the fluoroquinolones, both in of course the resistance and then the side effects. So I know it's a big question, but then maybe in the context of what you presented, how do you see the matter?
Yeah, let me explain a little bit short story about the fluoroquinolone itself, because they have been developed during my career and I had the chance to use them quite much and then reducing down. The fluoroquinolones are not good for the gram-positives, as you know. And for community acquired pneumonia, the problem bacteria is the pneumococci itself. And we were using macrolides, doxycycline, other tetracycline, and quite often, and the amoxicillin, of course, but because of the penicillin resistance increase in the 1980s or the year 75 to 80s, and the penicillin resistance is a surrogate marker for the resistance to macrolide and the doxycycline. I didn't go into the details of this because it's changing from country to country. For example, if it's more than 15% resistance, you cannot use those antibiotics empirically. And Spain, I'm sure Miguel is reading that quite often, it was one of the countries with the penicillin-resistant pneumococci, from USA to Spain and then to the Eastern Europe. The medical world need better antibiotics for pneumococcal infections in general, who are resistant to penicillin, doxycycline, and macrolides. And at that time, industry was, or the scientist was looking for the possibilities. And the most successful candidate was quinolones, because those quinolones that we are using those days ofloxacin and ciprofloxacin. They were mainly for the gram-negatives, but because of the chronic obstructive lung disease, doctors were accustomed to use cipro for the treatment of that, although it was not effective against pneumococci. So the scientists have started to look for a quinolone that will be effective to pneumococci as well, because they are covering all the others, Haemophilus influenza, Moraxella, all atypicals, everything. So what is missing is pneumococci. And as you all know, ofloxacin has better activity to pneumococci or gram-positives in general, comparing to ciprofloxacin. When they have studied ofloxacin, it has been understood that it's the chimeric structure of L and D form of ofloxacin. And when they have separated them, they have seen that the gram-positive activity is coming from L ofloxacin, levofloxacin. So they have isolated that and come out with levofloxacin, who has the gram-negative activity, atypical activity, and better activity to pneumococci. So because of that resistant problem, levofloxacin boomed out. It is the grandfather of respiratory quinolones. And then they have developed gatifloxacin. It has gone out because of the liver toxicity. And then we had travafloxacin. It has gone again because of gatifloxacin for the diabetes, travafloxacin for the liver toxicity, and finally they could come out with moxifloxacin. That is the real first respiratory quinolone. And then finally, I don't know, do you have that in Europe? But we have gemifloxacin as well. And I don't have time to go into the details, but just make it brief. Levofloxacin is not a real quinolone, respiratory quinolone, because it has a window selection of resistance, but moxifloxacin and gemifloxacin are the real ones. So if you want to use quinolones, you have to prefer those. But we do not prefer in the first line anymore, as Thomas said, because it has a black box, lots of side effects, like the QT prolongation and the nightmares accumulating in the knee or the other part of the body, and causing the tendon ruptures or arthritis. So it's not first choice. But if you have tried ofloxacin and macrolide before and no progress, good progress, or if you're in the country with the high resistance levels to penicillin and the macrolides, then you can go into the quinolone in rare cases. But again, underlying that, it must go with the start with moxi or gemifloxacin. I don't know, was that good enough? And if you have time, I would like to lecture about the pharmacokinetics of those respiratory quinolones. Which one is choosing resistance, which one is not choosing? Because during those days, we are not only running after the treating the patients. Of course, it's our first target. But the second rule, do not help developing resistance. Do not select the resistant ones. So it's a different story.
Great. We have some questions from the audience. The first one is an anonymous question, and he's asking about the role of presepsins, this toll-like receptor that have some studies about infection marker in sepsis. So they're asking if there is some role of this marker in community acquired pneumonia.
You mean procalcitonin and CRP, or?
They are asking for presepsin, which is a toll-like receptor, which I think we don't have in our hospital, in our common practice.
Well, it's not available in Turkey, and we don't have that in our practice. And it's a quite new subject, and we don't use it. We don't recommend it, actually.
Yeah, we neither at my hospital. I don't know if Thomas has the opportunity.
Yeah.
These kind of new markers.
Well, I had to Google it.
Okay. There is also one person asking about the role of lactic acid, if there is some role as a marker for predictor of severity, despite from the sepsis.
Yeah, we didn't go into the details, of course, because the subject was restricted. You know, the 20% of the pneumococcal pneumonia is bacteremic, and it really causes septic clinical picture. If the septic picture is on, if the blood culture is positive, of course, lactic acidosis is a good marker, like in the all other septic conditions. We can follow that.
Great. We have some more questions here.
Bernardo is asking, did you review the debate, treat or not to treat outpatient atypical pneumonia with macrolide? Last time I reviewed some years ago, the outcomes didn't seem very much when adding macrolide to treat atypical pneumonia, even in comorbid patients. Has it changed?
Well, atypical pneumonia, when we say atypical, it's not typical lower. It may be Legionella, it may be chlamydia, it may be mycoplasma. We generally define them as atypicals, but they're different from each other. For example, Legionella may be a quite light clinical picture or quite septic one. Mycoplasma is generally not very severe, a light one, and the chlamydia is also like that. And if the patient is severe, and if you have diagnosed, for example, Legionella with the urine antigen, and you have to treat it, you can do it with macrolides because there's no resistance in any of the atypicals to macrolides yet. But of course, if it's a severe case, you have to prefer the IV macrolides, like clarithromycin mainly. And for the other positive agents, macrolide is not problem. And I don't understand over here, adding macrolides. We have to underline one more time, beta-lactam antibiotics has no activity against against the atypical ones. So we can treat both pneumococci and atypicals with macrolide. But the problem over here is not the atypicals, but the pneumococci, because the macrolide resistance is changing somewhere between 3% up to 30% in different parts of the world. And the alone macrolide may not be enough for particularly the bacteremic one. There's no problem with atypicals, but with the pneumococci. So we have to combine, or you can treat alone with the amoxicillin clavulanic acid or penis-amoxicillin alone. But this time, if you miss the atypicals, you will be failing again. So we are combining them. And another interesting point, again, from Spain studies, when you add ceftriaxone plus macrolides for pneumococcal pneumonia, you get better results using each of them alone. Of course, the explanation for that, macrolides has anti-inflammatory action as well. So they are helping to fight against the inflammation and getting the better results. I don't know, I made it a little bit complicated, but could Bernardo Pimentel got his answer? Macrolides can still be used for atypicals, in short.
Pretty related with this last question, another person in the audience is asking, well, she's pointing out that his hospital policy is to stop the macrolide when the urinary antigen for Legionella or the throat swab for Mycoplasma is negative, only to keep them amoxicillin. But its guidelines recommend anyway keeping the double antibiotic for minimum 5 days. So he was trying to, his point is, if there is evidence for keeping the B therapy, or we should stop this when we have this test to rule out these two microorganisms.
Yeah, Legionella and Mycoplasma make vast majority of the atypical ones. If you can rule them out, you don't need macrolide anymore. It means it's pneumococcal, and you can go on with the amoxicillin or co-amoxicillin alone. Again, these guidelines has minor changes from country to country. It depends on your own practice, actually, what you have seen before. None of them is wrong, actually. You can run both. Of course, stopping macrolide as quick as possible in the patients with comorbidities, with the elderly age, will help you to protect these patients from the side effects. So again, it depends on the who is the patient and what is the clinical situation. You can go in any of them according to those factors. None of them is wrong.
Yeah, we usually continue due to this immunomodulatory effect in our hospital.
Anti-inflammatory effect is also important.
Yeah.
August is thanking for your great presentation. He's asking, should gram stain and culture be taken from lower respiratory tract secretions during the diagnosis of community acquired pneumonia?
Well, the culture, sputum culture, is not very valuable, as you know, because you get it through the upper respiratory with the contamination. If you have chance and you do the bronchoscopy and get the deeper sample, it helps better. Or if there's pleural effusion, you can take the sample out there. But generally, sputum culture, you must get it. And the smear of the sputum is even more valuable because you can look at the existence of the white blood cells. If there's more than 20-25 white blood cells in the 100 enlargement looking at, it means that material is infected. And if you make a good gram stain and see the gram-positive diplococci, then you can even diagnose the pneumococcal pneumonia. But the key, the thing that mustn't be forgotten, if you have a patient hospitalized with pneumococcal pneumonia or community acquired pneumonia with high fever, you must get blood culture. That is even more important because this is the only way to catch the bacteremia, and of course it changes everything. So the sputum culture not very successful or not very good, but the smear is good, help us a lot, and the blood culture is even more important.
There is another question. Should each country have its own recommendations for first-line antibiotics in CAP due to their own resistance in their own countries?
I would offer, I mean, if you have a strong community, I would advise to write down your own guidelines for community acquired pneumonia. For example, in Turkey, we are a group of people composed of the pulmonary medicine doctors, internists, and infectious disease. We get all the other guidelines in front of us, the latest one, and we study them, and we get our resistance. For example, in Turkey, pneumococci is suffering from resistant problem for macrolides, for doxycycline. So we try not to include them. And it may be different in the other countries. So I would advise to have their own guideline for that. But of course, guideline doesn't mean that you will always follow that. I mean, guideline is guide. It's up to your decision. So if you know enough about the resistant problem, you can make your own way.
Yeah, I think that's a very good answer. It's impossible to make an antibiotic recommendation globally because the resistance patterns are very, very different, and also the antibiotic stewardship must be according to the.
I used to joke about that quite often. There are so many guidelines, so we need guidelines for guidelines. And here, finally, I was in this situation. We made a guideline, appraisal, for the other guidelines for internists. There's no end for
Yeah.
that.
Yeah, but I think in this today's world where we are really suffering from the antimicrobial resistance,
Oh, yeah.
it's important to, because these are drugs that we can lose. So I think it's in this setting, I understand the guidelines that you to keep our antibiotics working.
Yeah.
There was one question from Bernardo. Did you plan on your PICO any way of differentiating viral tracheobronchitis and viral pneumonia from bacterial? I see often confusion here.
No, it was only for community acquired pneumonia, actually. The first thing is the diagnosis of community acquired pneumonia. And after that, we address for the viral ones to differentiate that. But if there's no infiltration, no pneumonia, guideline is not for that, not bronchitis and other issues. I understand. I was trying to explain the how we did the appraisal. But I understand, I see that the questions are always, or they all are clinical, either diagnosis or the treatment. So if you have time after the summer holiday, I'll be more than happy to lecture about that. Or I advise you, obviously there's a need for that, for the diagnosis and the treatment of the community acquired pneumonia in the area of antimicrobial resistance.
That would be amazing.
Yeah, I think maybe that's a good point, a good comment to end, and we would love to have you again to speak in the Young Internist webinars.
I'll be more than happy to present another lecture whenever you need that. Thank you.
So
I think we are done.
yes, thank you, Serhat. This was really nice, and
Okay.
I learned a lot myself also, and thank you for your work.
From old internists to young ones. Thank you for invitation. Bye-bye.
Bye bye. Have a nice summer.
Bye.